Good morning. Welcome to this morning's Tuesday lecture, which will be held by Francesca da Canal. Francesca is originally from Italy and is beginning her third year of surgical residency at our department. She has a personal interest in endocrine surgery and will be talking about what to do with thyroid nodules. Enjoy.
So thank you very much, Diana, for your introduction and your help. Today I will speak about the approach to thyroid nodules. I will go to the incidence and the epidemiology, clinical manifestation, diagnosis, and treatment. A thyroid nodules is a discrete lesion within the thyroid glands, which can be radiologically distinct from the surrounding parenchyma and can be palpable or not palpable. The thyroid nodules are pretty common. Up to 30% of the population have at least one thyroid nodules, and the reported prevalence depends on the population studied and the method used to detect the nodules. So numerous studies suggest a prevalence of 2 to 6% with palpation, from 19 to 35% with ultrasound, and 8 to 65% in autopsy data. So the important message is thyroid nodules are common and they occur more with the age. Their incidence is increased in women and in people with iodine deficiency and after radiation exposure toward the neck. So now the important question is, how often do you think it's a nodule malignant?
I would guess around 10%.
Yeah, I agree. So a nodule is malignant about 8 to 16%. So most of the thyroid nodules are benign, and benign nodules are usually colloid nodules, cystic lesion, and adenomas. Malignant nodules can be divided into differentiated carcinoma. The most common is papillary carcinoma, up 60 to 80% of all cases, followed by follicular carcinoma in 10%, or poorly differentiated medullary and anaplastic carcinoma in 5 to 10% of all the cases. So now let's start with the clinical case. A 28 years old female general surgical resident, then during an ultrasound course, discovered to have a non-palpable thyroid nodule, an incidentalloma. So the concern to have a thyroid nodule is that it can be a thyroid cancer. We will start with the anamnesis. And first of all, it's important to exclude the risk factor for thyroid cancer, such as a story of neck irradiation or a first relative with a thyroid cancer. And after that, it's important to investigate the symptoms. So which symptoms are we looking for?
Maybe changes in weight, hair loss?
Of course. So we are looking for symptoms for hyper or hypothyroidism. And then it's important to ask how fast is the nodule growing and if is there any change in the voice or hoarseness. In the clinical examination observatory, we can have a look if is there any visible nodule, a goiter, or a big tracheal deviation. A nodule is palpable or fixed to the surrounding tissue, and if is there any cervical lymphadenopathy. So what do we do next? Next, we want to test the thyroid function. To accomplish that, we need to take blood samples and test the TSH. After that, in every case, we will do a sonography, and if the serum TSH concentration is low, so if we are in case of a thyroid hyperfunction, a scintigraphy should be performed. From the different scintigraphy results, it can be differentiated a diffuse autonomy of thyroid, which suggests a grave disease, or an autonomous nodule like a toxic adenoma, and therefore we can suggest a therapy. And then, by the other hand, if the TSH is normal or elevated, such as in our clinical case, and that means if we have a thyroid normal or hypofunction, a sonography should be performed. So we go for an ultrasound, and the lymph node of the neck should be included. In the ultrasound, we can assess the nodule and the suspicions finding for thyroid cancer may be highlighted. For example, irregular margin, non-oval-round shape, microcalcification, and we can evaluate it if is there an association with abnormal cervical lymph nodes. According to their sonographically malignant feature, all nodules are classified into the OI-TRADS classification. A nodule OI-TRADS 2 is almost always benign, and the nodule OI-TRADS 5 has an high risk for malignancy. So do we need a fine needle aspiration biopsy? So we need it for low-risk nodule bigger than 2 centimeters, so thyroid 3 nodules. For sonographic intermediate risk nodule bigger than 1,5 centimeters. And about TRADS 5, so high risk nodule, any nodule bigger than 1 centimeter should be biopsied. And for nodule TRADS 5, which are smaller than 1 centimeter as one of our clinical case, it suggests an FNA or an active surveillance. Well, in our clinical case, we had a young patient, 28 years old, with a nodule with high-risk features for malignancy. And she really wanted to have a diagnosis, so we just went for an FNA cytology. So the histology of thyroid nodules can be classified into T classification. T1 to non-neoplastic lesion to T5 diagnostic for malignancy. And according to that result, it can be defined the best therapy. A T1, it's usually non-diagnostic, so the FNA needs to be repeated. A T2, it's almost always benign, so we can go for a follow-up. A T4 and 5 are most of the time malignant, so we go for surgery. And what about T3? A T3, it's a follicular lesion, but in a thyroid follicular lesion, the difference between a benign lesion, such as an adenoma, and a malignant lesion, such as a carcinoma, cannot be detected on the FNA because it's about capsular invasion and other macroscopically characteristics. If we have an histology of T3, we have a 15 to 30% of probability that it's a malignant nodule, so we will go for surgery anyway. In our clinical case, we have a T5 histology with a nodule smaller than 1 centimeter. That means a papillary microcarcinoma. So it was a good idea to take an FNA, and now the question is, do we have an indication for surgery? So we go for surgery in presence if we have a nodule with determined local symptoms, if we have an hyperfunction due to an autonomous adenoma bigger than 3 centimeters, because if it's smaller, then we can maybe perform a radioiodine therapy. And is there any suspicion for malignancy because of the FNA results? So the last time that we go for surgery is if we have a nodule bigger than 4 centimeters. And why? Because, as shown in the study of Worley, which was a retrospective study that analyzed 382 patients that went for thyroid surgery with nodules bigger than 4 centimeters, in that case, there's a high rate to obtain a false negative result in the FNA. And in particular, the probability is up to 10.4%. So the risk to have an undetected malignancy in case of a thyroid nodule bigger than 4 centimeters, it's about 25%. And that's why we always go for surgery in that case. Pre-operative, we need to obtain an head-neck ultrasound, including lymph nodes. For advanced disease, we need to perform a CT scan or an MRI in order to obtain a correct staging. And we need to have an assessment of the vocal cord, and a normal thyroid function must be achieved. With pharmacological treatment if needed. So what kind of surgery we will perform? We can remove the entire thyroid gland with a total thyroidectomy, or we can remove just a part of it with a lobectomy. And then we can perform a lymph node dissection or not. So we usually go for a thyroid lobectomy if we have a benign disease with surgical indication. If we have a malignant disease, about 1 or 2 centimeters, up to 2 centimeters in Europe and up to 4 centimeters in USA, agreed with the ATA guidelines. And if we don't have any extrathyroidal extension and no lymph nodes are involved. On the other end, we will go for a total thyroidectomy if for any malignant disease from 4 in USA and or with extrathyroidal extension, positive lymph nodes, aggressive histology features, contralateral nodule, and if the patient is older than 45 years, and if we had an exposure of radiotherapy or a positive family history for thyroid cancer. After the thyroidectomy, we can perform a central or lateral compartment neck dissection for a patient which have an involvement of central or lateral neck lymph nodes. And that's to provide the clearance of disease from the neck, depending on staging and histology. So depending on postoperatory risk stratification, the patients can be divided into low, intermediate, and high risk stage. And according to that risk classification, there can be the indication for additionally radioiodine therapy, TSH suppression, and follow-up frequency. So the take-home message is thyroid nodules are common, up to 65%. Most of the thyroid nodules are benign. All nodules need a TSH and an ultrasound. Only patients with hyperthyroidism need a scintigraphy, and nodules on ultrasound are classified according to thyroid system. And FNA should be performed according to size and thyroid classification. And the indication for surgery for thyroid nodule are local symptoms, malignancy, and autonomous adenoma bigger than 3 centimeters. Thank you very much for your attention.
Thank you, Francesca. Very nice. I just want one comment to the take-home messages, because if you see that up to 65% of people have nodules and then 20% are malignant, then that would be a bit of an overestimation. I think it's because the 65% are autopsy studies, and the other ones of 10% of the nodules that are clinically apparent and that are, examined will be malignant. So it's not quite. That's a bit of a discrepancy there. But otherwise. Any questions?
Why is this difference between the US and Europe?
The American Thyroid Association gave out new guidelines in 2015, which were very different from the ones before. Upon data showing that basically up to 4 centimeters, there's no good evidence that a total thyroidectomy is better than a hemithyroidectomy. So that's why that data exists. It's the best we have, but Europeans are more reluctant to go that far. Before 2015, every nodule bigger than 1 centimeter malignant would have led to a total thyroidectomy. So basically there's a trend towards less aggressive surgery. There's a trend to maybe do more lymphadenectomies, but less surgery. So there's no good data between 2 and 4 centimeters size, and Europeans are, and Also in the American guidelines, you're allowed to do a hemithyroidectomy or total thyroidectomy between 2 and 4 centimeters, but it's also allowed to just do a hemithyroidectomy up to 4 centimeters, which will, in Europe, we're just more conservative. Yeah.
So radiation X-ray is a risk factor to develop malignant nodules. Many of us use probably also X-ray in the OR, either by IV placement lines or other procedures. Is there anything known from the professional side if they are at risk?
That's a good question. I guess if you go over if you have a high exposure, I'm sure that also has a risk factor, but that's why we will have the special measurements for the neck. But I'm not aware of any data. Not aware of. Any other questions? So then thank you very much.